My name's Laura Lear, and I'm the managing director here at Ambitious. We're a strategic comms agency. So really excited about this conversation today. We do a lot of work in the health space and wanted to kind of bring to life some of the issues and challenges that a lot of clinicians and entrepreneurs are facing within this area. So I'm going to do a bit of an overview of the session, and then I'm going to introduce my panelists here as well. So with the new 10-year NHS strategy on the horizon, the system is entering a period of major change with innovation firmly at the top of the agenda. So for many clinicians and leaders, obviously translating ambition into practice still remains quite difficult. There are lots of structural constraints, funding mechanisms and cultural barriers continue to limit progress. And obviously a growing number of clinicians have had to step outside of the NHS to actually pursue innovation elsewhere. For those who remain committed to the values of the public healthcare system, this raises important questions about how new ideas are developed, sustained, and ultimately reintegrated to strengthen the NHS. So my panelists today are Dr. Krishan Ramdoo, who is the founder of Timber Health. Now, Krish is an international speaker, researcher, educator, and clinical entrepreneur. He started his medical career at Oxford and went on to become an ENT surgeon in London, and then shifted out into the private sector to pursue his passions in this specific space around hearing and ear health. So I'm really excited to have Krish here to talk a bit about some of the challenges and also opportunities he's seen through his journey. So welcome, Krish.
Thank you.
And also Professor John Terry. So really excited to have John here. John Hook has come from a very different background. He's a mathematician, but he is the co-founder and managing director of Neuronostics, which is all around transforming epilepsy care. And John combines commercial acumen and academic excellence to drive the company's vision. He was awarded the Tech Spark Founder of the Year in 2024 and the recipient of the Tech Southwest Leadership Prize in 2025. So really interested to hear a bit more from John as he works with many of the NHS trusts in terms of how he's been able to navigate some of this and some of the challenges he's witnessed as well. So thank you both. I will just make a note that unfortunately Louise Newsom's had to send her apologies today and is unable to make it due to a major clash of diaries. So we won't have Louise with us today. So we're going to run for about 35 minutes. We're going to get into it now and then we'll take any questions. So thank you both. So what is innovation? Starting with the kind of the NHS, because obviously you're working in this sort of, I know, Krish, out building your own business in the private space and scaling it. But how is innovation currently supported in NHS in terms of grants, funding pathways, and support networks? And can I start with you, Krish, on that question?
Yeah, and thank you for having me. Really looking forward to the session. And I think innovation is evolving in the NHS. I think we at Timber Health, we've been around now for about nearly 6 years, but obviously I was a practicing clinician for about 10 and a half, 11 years before that. So, going through all of my training, and innovation was, challenging because I think medicine, there's a very clear-cut path of how things are done, treatment pathways, but research has changed the way we should deliver treatment, but actually also innovation and embracing innovation. I think I would certainly say in the last 2.5, 3 years, the NHS has got better at embracing innovation. I think it's become now a new way of thinking with the advent of AI, the advent of actually clinicians wanting to do more and learn more. And, if I take it to my journey, I founded Timber Health because I was actually living the problem that I wanted to address. I was seeing all these patients in my specialist clinic, and I thought there has to be a better way of how these patients that are coming to my clinic, I need them to be the ones that I need to see, the ones that are complex. And it was very hard back then to think about how I could get some headspace to think about innovation. So what I did, I stepped out and did a PhD, whereas now, and that gave me some headspace to think about that, but now there are programs which the NHS are supporting, which is helping drive innovation. One, which I was one of the first cohort to be part of, the NHS England Clinical Entrepreneur Program, which is where they look at clinicians or allied health professionals with good ideas who are either, what they're calling them, either entrepreneurs or intrapreneurs. Intrapreneurs being those that want to innovate within the system. And that has been really supportive because it talks to you how you can engage with stakeholders and where our funding is always a challenge. There's obviously the National Innovation Accelerator as well. But also, there's always good pots of money that the NIHR and Innovate UK have available. So we've been really fortunate to be the recipient of two AI grants and loans. They are very difficult to get, but actually they are funding projects if they're unique and obviously fundamentally good use of public funds. But I do say with some optimism that the NHS is embracing technology, but it is long and hard, and it is at the moment you need to have some really good data in order for them to take you on.
John, what's your thoughts on that? Because you come from a slightly different perspective.
Yeah, I guess I come from the sort of outside in rather than the inside out, but that was a really interesting story. And I think that final comment about data being key is the one that I would focus on. So our company, Neuronostics, we're a software as a medical device, and our background was spun out of the University of Exeter, and we're focused on developing tools that enable better decision making in diagnosis and prognosis of a condition called epilepsy. So our research essentially enabled understanding of how seizures could emerge in large-scale brain networks, and the challenge was to develop a tool that could actually bring that power to bear on data that's being routinely acquired in clinics all around the country, which seems a simple concept in principle, but the challenges around generating that data, generating the proof of efficacy that's absolutely key for tools to be taken up, has been quite a long journey. And in terms of how that's been funded, I mean, perhaps if I just mention some of the external schemes available, we've been supported along the way by Innovate UK, by NIHR, by SBRI, which are now kind of called Contracts for Innovation. These are all grants or contracts that enable you to generate crucial evidence that hopefully demonstrates that proof of efficacy and de-risks your company from the perspective of private investment, because actually another really crucial area is going to be private investment. Almost all innovative companies, especially in the medtech space, we're going to be at what's called that pre-revenue stage for quite a long time. And so being able to raise money through private equity is also going to be pretty important along the way. And I think some of the real challenges, I guess, is adoption at scale is kind of really key when it comes to innovation, because you can often get, like Dr. Krish, really innovative doctors who really want to make a difference. They're quite easy to find and engage potentially. But where the innovation becomes more challenging is, what's your regulatory status? What's your digital certifications look like? All things that other parts of the NHS need to understand in order for you to start seeing whether your innovation is really going to have an impact on patients. And I think a lot of the time these things don't get looked at early enough, soon enough in the journey, which can then really, I guess, derail things later on. I mean, I'm curious, it's really great having someone who's done this from the inside to hear whether you face similar challenges or whether sort of being on the inside has given you a bit of a head start in some dimensions and perhaps not others.
Well, should I answer
Yeah,
that? Because
absolutely.
actually, you're right. I mean, I think in some ways it's very helpful to be on the inside, because actually you can know the stakeholders, those that you need to influence, those that you want to also be your champions. I think the challenge also that can get you to a certain point, but then when it comes down to the contracting, you're then automatically seen as the commercial organization, and you have to kind of let a group make a decision. But you're right in terms of John of thinking about things early, because fundamentally I had an idea and I was like, this needs to be solved, and I kind of went head on to kind of solve for that because I was living it day in, day out. But very early though, I think I was fortunate to get that advice on, think about regulatory. This is a hardware and software solution. So some people may not realize that as much as you may even have a product, you can't actually get it into the market if you don't do that regulatory journey. I think that's a really good point to say that sometimes you can miss that. But I would say overall, to answer your point about being on the inside, I think that has been helpful, because I think not only knowing the stakeholders, but actually understanding the pathway. Because for any innovation, you're doing it for patients. Where does the patient enter into the pathway? Where do they normally drop out? Or actually, how can you shorten their pathway? Because if they need something doing, how do you get them to the right person at the right time? And equally with the kind of 10-year plan and kind of going towards this, neighborhood health model of into the community, what can be, we do ear and hearing in the community, but what are the other things alongside that? What can be seen suitably in the community? Because now patients, if you ask them, I'm pretty sure, want to be seen in their community rather than having to go to a hospital. They want to go to a hospital when they need to, when they're acutely unwell, which is obviously going hand in hand with what the government and the NHS drive over the next 10 years should be happening.
Yeah. And I'm just interested in kind of sort of moving on from that, John, how do you actually work with the NHS? You've obviously grew the business outside, but you do work with a lot of trusts. How do you work within that system? It's such a huge system. I know when we met and we had the briefing call, you talked about decision making being so challenging because there's, often it's moved or shifted onto the next person and no one has that accountability. So I'm just interested in your experience of working within the machine.
Yeah, I mean, I guess we were fortunate that for many years before spinning out the company, we were sort of more traditional academics, if you like. So we had the freedom to work with different clinical teams on projects of mutual interest. So a lot of the early work that we conducted was in partnership with epileptologists at King's College Hospital, part of KCL, over in London. And this gave us a real opportunity to sort of develop ways of working that valued, I guess, each discipline equally. I think one of the challenges in this space now is that no one discipline, certainly not in epilepsy, and I'm sure the same is true in ear health, no one discipline is going to make all of the differences you need.
Yeah.
You want to build a company, you need scientific excellence, you need clinical excellence, you need regulatory understanding, you need business development and partnership skills, you need the operational nous to actually make things work. So learning those skills early and understanding how clinicians think, what their pain points are, that was really key because it helped sort of frame the narrative around some of the fundamental tools that we were using. And then more recently, we've built out relationships with colleagues across the country in different environments. A lot of the work we do now is down in Cornwall. Many of the challenges that Dr. Krish mentioned in terms of rurality, wanting to be treated in the community, they're especially acute in Cornwall. So for neurology, there's a single hospital in Truro, which has 2 neurologists, and they serve the entire population of Cornwall. It's about 500,000 people. Cornwall stretches from Bude, which is literally on the north coast, very close to Devon, right down to Land's End. Truro's kind of in the middle. But, if you've got to get public transport to Truro from one of those extreme points, that's a 3 hour plus journey. And if you have epilepsy or suspected of having epilepsy, you've probably lost your license. You can't travel by car easily. It's really, really messy. And that's why, a lot of this community-based diagnosis and management, I think, is going to be really, really key for these sorts of underserved communities.
And do you think this could go to either of you that actually, we've got the NHS 10-year strategy, and I know that a lot of that is around driving innovation, but is it about private and public sector working together to really drive innovation? Is that the key?
I think that it will have to be. I mean, I think you could argue what we want in an ideal world is that the NHS is such a big institution, and equally, it's a great example of healthcare across the world. But in reality, the system is really challenging to navigate as a patient. If you were trying to get healthcare, it can be very difficult and very challenging. And I think sometimes there has to be the right way that private and public can come together. You could argue it may be inevitable that that's what's going to have to happen. But I think as long as it's done in the right way, and it's easier said than done, what you want is put the patient first, and then the system should be able to evolve around it. But equally, one of the things as well is it is costly to sometimes think of it that way. And so how can you marry the two together? And certainly as a private entity, you are a private company, so you do have to be able to run like a private company and equally have your own costs to deal with. But in terms of the future, I think it can be done in the right way. Like the way that we work with the NHS, I think maybe it's a different example, but we are working with the NHS with individual ICBs to give them our technology so that they can deliver a service. Obviously, we have a contract with the ICBs then deliver the service. But so there's ways of it working. And then we have just molded to the way that those ICBs want to see their patients. And I think that's how you have to do it in the right way, rather than say, okay, here's a private organization. The NHS needs to mold into how we want to see the patients.
Yeah.
I think that there needs to be a fine balance between the two.
So what's your experience been then, Krish? I know we've spoken many times, but for the listeners here, in terms of moving out of the public into private and being able to then, really follow your passion and innovate. I'm sure there's been also restrictions in the private sector as well. So do you feel like you've been able to do what you need to do and you want to do? And I'm sure you're on a journey as well.
Well, there's more to do, certainly. I think what I am pretty proud of is that obviously as a single ENT surgeon, I don't think I would have been able to help or support as many patients as we do today. We have, over the last 5 years, developed this ear and hearing technology, which does the true end-to-end assessment of ear and hearing and pushes patients when needed to the right place at the right time. And currently there's about 40,000 patients a month which go through our journey. So really good validation. And I think the bit for me, and particularly with the NHS, I needed to prove that data in the private sector for the NHS then to look and be like, well, this is a validated product now.
Right.
But then what we then needed to do was then do another pilot of a certain volume. I think we did 8,000 patients to prove that it can be delivered in the community. And then now we're in that extension. And, it's someone told me this the other day, the NHS may do or have more pilots than British Airways has, something like that, because that is one challenge that we have. There are constantly pilots, as opposed to you've proven the evidence base, let's go for it. And I understand the nuances around it, but I think that's one thing we could do better. If there's true evidence base, adopt the technology.
And John, what's been some of the biggest challenges you faced when it comes to, obviously, with your business, growing it and obviously working with the NHS?
Yeah, first of all, just to answer the sort of original question, I think it's critical for private organisations to be working with the NHS in partnership, because the NHS has all of the clinical expertise. It's got some great, research base within its staff, and obviously the data that comes out of NHS trusts is second to none. One of the real challenges, I think, is perception. Historically, there's always been this kind of concept that the NHS is this sort of last bastion of kind of public service, and, commercial entities are evil and never the twain shall meet, etc. And I think we've got to break those barriers down. In terms of some of the specific challenges that you're likely to encounter, and be curious to hear whether Dr. Krishan, in his experience, has faced some of these. I think, there's fragmented procurement processes. There's a myriad of different procurement frameworks, and different trusts use different procurement frameworks. There's reimbursement gaps. So you might have the evidence that your tool is cost effective, but the mechanisms via which those cost savings are realised may be hard to articulate or even be understood at a trust level, because part of the real challenge is ultimately who pays effectively, and it could be like in our case, we straddle neurology, neurophysiology. You have some care taking place in primary care, some in secondary care. All of this is rather distributed, and it's not exactly clear who in the first place should pay and how do the savings that are generated get accounted for because they're all distributed over a variety of different sources. And that's one of the real kind of challenges, I think, in terms of getting adoption is when that clarity doesn't exist, then you're bringing together lots of different parties. Risk and risk aversion are necessarily kind of important things. We don't want to do harm to patients. So, we must be risk averse. But how then do we create the environment where all of the evidence is assessed in a kind of unbiased and, pragmatic way to determine how should we bring benefits, especially where the data does exist, to bring those patient benefits?
Well, I will say, John, if I can come in, you're right on the evidence base, but the independence, I think the big thing that was the trigger for us was although we were collecting the data, there was an independent evaluation which took place, which proved that actually, even if we had packaged the same evidence base, the fact there was an independent evaluation, I think that gave them confidence that actually you are reducing referrals into specialist services, which was the remit of what we wanted to do to help reduce the waiting lists. But it was that external validation that was the trigger, even though previously we had that data and we were saying this is what we can do. I think that is a key thing that helped our own adoption into the system.
Yeah. And just sort of slight shift. I'm interested in your perspectives on this before we open up to some questions as well. But what would a genuinely innovative or innovation first NHS look like in 5 years? Big question. What are the things that need to happen?
Well, I think actually John alluded to some of it actually, because I think the procurement, I think that what is a challenge, even though we have been fortunate to have some good traction with the NHS, I'm still having 14 different conversations with 14 different ICBs and a very different procurement process. Who are the stakeholders that I need to speak to? How can you bring them all together? I think that is a really challenging. So I think if there was a way, if you had a magic wand, a central procurement process, a central process that is how should you adopt a minimum level of evidence that's required, that means that in order to get to that minimum level of evidence, there is routes for a pilot. And I think with that, then there's constant review of that. But equally, in the NHS, the way the procurement works is an annual process. So what you don't want to do, and what we have had to do, is then you go out to procure again. So at least if there was a minimum, I mean, I'm not saying we've had challenges before is that people get awarded contracts for a significant period of time. I wouldn't be suggesting that, but certainly give 2 years at least for evidence to build up. So I think there's a couple of things there, but I think if there's a bit more standardization, I think then everyone knows what they're doing, rather than, to be fair, any new company coming in, or even in these, one that's been around for a while, you're kind of figuring it out as you go along. It's quite a difficult process to navigate.
I'm sure. John, is there anything to add to that?
Yeah, I mean, definitely echo that challenge of, who are the right people within a trust to bring together to make the decisions, because often it's not even known within that trust. I mean, we've had scenarios where everyone thought they were in a position to go, and then at the 11th hour discovered that there was another level of sign-off that no one had even previously been aware of, and it was just by chance that someone was talking to someone else over coffee and mentioned what they were doing, and then this suddenly started a whole new load of approvals in process. So I think that pulling together is going to be key. The other thing I think in terms of it gets back to Dr. Krishan's comments around independent evaluation. That can be pretty challenging to deliver. And so are there ways, for example, that if companies have had, Innovate UK grants, they have had NIHR funding, the evidence base has been developed to a level. Is there a way to then have a specific pot of innovation funding available that enables trusts to bid into and conduct that evaluation in that independent way? This is the other comment I think was really critical from Dr. Krishan was about the time. So in our space,
Mm.
epilepsy, it takes a year or longer to confirm a diagnosis of epilepsy from first presentation. So if this pilot, for example, is only funded for a few months, that doesn't actually give the time to generate the evidence that the tool is adding value in the way that the research study suggests is the case. At the same time, I can see the challenges with, committing 3, 4, 5 years of budget to one particular tool. So there's some really quite challenging trade-offs that we have to collectively think about how to best handle. But I certainly think creating these kind of more, specific pots for trialing tools that have proven evidence and that have often received significant government support. In our own case, if you look at all of our Innovate funding, NIHR funding,
Mm.
we've had over 3 million plus pounds in government support to get this to this point. If it was then to sort of crash and burn because the actual adoption, the
Mm.
actual real world evaluation was just impossible to deliver, that would be a significant waste of public resource. And so thinking about how you can leverage what's come before, I think is really important.
Brilliant. Thank you. We've got quite a few questions coming in, so I'm just going to start picking a few out. So we've got one here. Would you ask for a payment contract in place to get a pilot running?
In an ideal world, yes. You would try.
Yeah.
I think that the challenge is that it's if you think about budgeting cycles within the NHS, obviously they have it from April to March. I think it's when you enter. Some of them, it's how you find that pots of money, but there's pump priming funds that
Yeah.
sometimes you can get access to. But ideally, yes, because at the end of the day, you're also having to invest to deliver the service. So I think you should go in with that. But I think in my experience, you have to be able to almost absorb some of that cost to get the evidence going and play the long game, which is never easy. And
Mm.
probably one bit of advice that I took that we never really built a full business plan based on just NHS numbers. We had to build a business plan that had, private sector funding as well.
Yeah. John, anything to add to that?
Yeah, I mean, I think a colleague of ours used the phrase value exchange when it comes to how to frame
Mm.
a pilot negotiation. So, you might say that you believe in your business model, that your tool has a certain price point that you believe is the price point that is justified by the health economic evidence in support of your tool. But if no one's really using it up to that point, you have to recognize that you may not be able to command that sort of price. But on the flip side, very often when it comes to sort of generating real world data, you can have the initial reaction being, oh, well, we're generating that data on your behalf, so you should pay us to generate the data for you. But if you frame it in terms of more actually, there's an exchange of value here. We're discounting from a list price potentially down to nothing in
Mm.
order to enable you to generate this data. Can we have that exchange of value? So, we can offer a discounted rate in exchange for
Yeah.
sharing data of efficacy, publishing that data. I always think it's really important to have clear agreements around the desire to publish data so that you're being totally transparent about how your tool is working and being utilized. Then I think, that actually creates a better environment and a better understanding on all parties as to what's really going on. And that's been a way that we've been dealing with the challenge. And it's making progress. I wouldn't say it's straightforward because, as we've heard, each trust does things differently. You've got to basically start again each time. And it's a challenge because by the time you've done 3 or 4, the policy landscape's changed, and then suddenly you're back to the beginning again and learning a new,
Or the people have
or the
changed
people have
as well.
changed.
Yeah.
Exactly, yeah. So
Brilliant. Thank you. That's really helpful. So we've got another one here. From an implementation perspective, would it be advisable to undertake a small scale feasibility or usability study first in order to generate preliminary evidence before seeking support from ICBs or secondary care organisations for a larger pilot?
Yeah, I mean, I definitely. I think
Yeah.
the thing. I think if you do that, that's just going to build the case easier. I think if you can do a feasibility study with probably everything that John and I have said of how you manage that effectively for your own cash flow, but that just, all these NHS organisations have to write a business case, and
Yeah.
having some real data is the best way they can sell it in.
Yeah. Sorry,
Absolutely.
John.
So just to add, I would also say it's always really important to work with a statistician at the earliest stages of these types of study design, because you may be pleasantly surprised and find that the numbers you need in a feasibility aren't as high as you expected. Alternatively, what you don't want to do is find that you are underpowered for determining any putative effect size, because essentially the idea of a feasibility should be to reduce the uncertainty around a subsequent larger scale trial. But you'll need a certain number of participants before the uncertainty is sufficiently diminished for that to have had any impact at all. And getting that balance right is really important, and is actually quite a hard statistical question depending on the area you're working in.
Brilliant. Thank you. So another question just on the sort of commercials, really. What actually unlocks funding? I think it's probably a combination, but is it great ideas, evidence, or relationships?
Well, I don't know if you want to go. I can go first, John.
I
It
can
seems like
go
we're.
first.
Yeah, I was going to say you
Right?
go first because
Okay.
otherwise we're going to go straight. Yeah, you go first.
I guess in terms of, are we talking grant funding or sort of NHS funding?
I think it's probably a combination.
Okay.
It hasn't been
Well,
specified.
I think in terms of grant funding, I mean, this has been my wheelhouse for a number of years, stretching back to when I was an academic. And in this case, I think there is an additional ingredient, which is to actually understand how to write grants. And that's not necessarily a straightforward thing. And especially as you move into a more commercial space, if you're writing grants for Innovate UK or NIHR, they can look very different to traditional academic grants that people may have experience in. And key to that really is, how are you presenting your ideas? How are you presenting your evidence? And how are you presenting the broader commercial ideas, the risk management, the project management, which are all things that traditionally get overlooked in academic grants, but are actually key in sort of Innovate UK, NIHR type scenarios. And bringing those ingredients together is what gives you the best chance of what I would term getting into the fundable region. There's still a lot of uncertainty in the system. You can't control peer review comments. You can't control panels' decision making. But what you can do is give yourself the best chance of being in the mix to receive a positive outcome.
Brilliant. Thank you. Krish.
Well, I think it is to unlock the funding. I think certainly from my perspective, I think what unlocked it for us was the evidence base. I think as soon as they saw that, and then I think John talks about a statistician, but equally health economics, because fundamentally you may have the best clinical idea, but if the numbers don't stack up, it will never get pushed through. So I think also having a health economist, or sometimes hospitals, or there's the health innovation networks, they have funding to help support that type of evaluation. So I would suggest that actually the evidence base driving the shift in money, which is moving the service from here to the community, let's say, I think that helps build the case. So I think you need to have that evidence base. It's very rare. You may know everybody in the NHS, have the best idea, but if there's no evidence, they're never going to adopt it.
Yeah, no, sure. And in terms of kind of your both your roles in kind of sort of founding roles, having peers to talk to and to throw ideas around, someone's asked here a little bit about the sort of communities you're part of, where you've been able to meet founding members within this space to really bounce ideas, share knowledge. And I think this particular individual is sort of talking about the fact that it's been, sometimes you can find these sorts of sessions, but other times it's really challenging to find the kind of opportunity to hear from people or to throw ideas around. Have you got any advice around that?
Yeah,
Well,
happy to
John.
jump in. Like from the sort of on the commercial side, we've been really fortunate to be part of various accelerators and incubators over the years. So we're part of Set Square Bristol, based at the engine shed in Bristol, which has brought together lots of different companies, but does have a focus on med and health tech. Building out of that, there's now a kind of broader, what's called the Western Associates for Med and Health Techs. It's a group of sort of startup scale ups in the medtech space. That's been quite a useful body because, for example, they've managed to get meetings with innovation leads at local trusts and getting collectives of us together to discuss some of the challenges in innovation. Just today, for example, I'm up in Future Space, part of the UE campus, another kind of incubator, accelerator type space. We've been running a session this morning on what was called the funding formula. So working with colleagues at Walmer who specialise in R&D, tax credits, and ourselves focusing on funding, exploring ways that founders can access funding and how to, take advantage of different government schemes available to support early stage ventures. I think these sorts of communities are really powerful. They often offer free to attend events, even if you're not formally part of them. So it's worth, getting on their mailing lists, getting out there, speaking to others, because that shared sense of community, shared sense of frustration, and maybe even sharing the odd success story is quite a powerful thing to keep you going.
I,
Brilliant.
I,
Thank you,
tot-
Chris.
I totally agree. I think having a network of people who are thinking differently, like yourself, I think is also helpful. I was lucky. There's the NHS Clinical Entrepreneur Program, which I think is now in its 10th year. And that's just not open to doctors, that's open to any allied health professional trying to make a change within the NHS. They do fantastic webinars, in person meetings, and creating a network of people. I think sharing ideas, and equally, you can guarantee, and even in John and I's, my journey, I'm sure that I've gone down some dead ends. John will have gone down some dead ends, and actually, the chances are we would have gone down the same dead end. And could one of us have prevented us going down there? I think sharing experiences is really, really important. But equally, whoever put the question, it's hard sometimes to find those networks. But I think if you do put yourself out there and are on forums and so on, I think you'll be able to get to events as well. And I think having a good network is really key to success as well, because it's never a straight line. And like I said, you will without a doubt have somebody within that network who's gone down the road you're about to take or at a turning point. So sometimes just having a conversation can make sure you get on the right route.
Brilliant. And what's the hardest lesson you've learned about turning a clinical sort of valuable idea into a commercially sustainable business? Rish, I'll stay with you there if that's okay.
I think the one, it's I guess I can answer it in two parts. One, it's harder than you may think. I think you almost have to be all in, because like with anything, and certainly my journey was, I wanted to help and support patients and people. So I had that as my North Star. But the hardest journey is like there is not an infinite amount of capital that you have within your business. It goes in stages as you get funding. And I think it's balancing the two. And certainly from the clinical background, I've learned that really well, because that was, the thing which I realized quite early. And the other part is it's not the most valuable lesson is to get the right team. I think
Mm,
you cannot do this on your own. You've got to be, as the founder, the guiding light of where the company needs to head. But you've got to be very quick to know what your strengths are, but also what your weaknesses are. And once you find out your weaknesses, is fill those weaknesses with people that's their strength. And I think that
yeah,
allows you to scale.
brilliant. John, anything on that?
Yeah, I mean, the team thing, absolutely key. And that, that ability to identify your own blind spots, your own weak spots, or having colleagues who aren't afraid to highlight those is going to be really key. In terms of sort of early lessons, how do you find the right expertise early on? How do you find impartial advice? This can be really challenging, drawing on our own experience. Spun out of a university, we're academics, we know nothing about running a company. All of a sudden, you're running a company. There's lots of people around who claim to be able to help you run a company. Maybe they can, maybe they can't. I think one of the biggest life lessons I've learned is that, if a commercial genius is hanging around a university offering to help early stage ventures, we have to question what the motivation there is. It could be that that individual is looking to give something back. Equally, it could be that they perhaps aren't as commercially successful as they might purport to be. And you need to be really careful because, unfortunately, there are a lot of vultures out there, and early stage companies are, a prime target, I think, for unwanted and unhelpful advice if you're not careful.
Brilliant. Thank you so much. We've got one final question and then we're going to wrap up. So it's just around the piloting piece again. So how ready should the product be when engaging on a pilot? Because often find that there are always something that's going to be needed to be improved on the product as the NHS team is using that. So do you need to do it? So if it's a fixed pilot, the outcomes won't be as good as after the improvements. And should they then be doing another pilot with the improved product?
John, do you want to go?
I'm sort of just thinking, keen to get your thoughts on this one, but to my mind, to have a pilot, you would have to have the product at least regulated to a level that meant it could be used in the NHS. So in some sense, there must be a sufficient evidence base to support its utility. Once you reach that point, there's probably an argument to say the sooner you can get it into the hands of people who can help you evaluate its real world use, the better. I would suspect there's that kind of concept in other walks of life that, if you wait until you're ready, you'll never do anything. I don't think you'll ever necessarily feel a product's entirely ready. But I think, there are that bare minimum. You need to have your regulatory status there. You need to have your ISO certifications, other things depending on the field in place. But after that, I'd probably support trying to get it into the hands of users as soon as possible.
Mine's very similar. I think one, having at least that proof of concept. I think on the regulatory, I think it really depends on the product, doesn't it? And actually, can you articulate a very clear regulatory pathway? And with that, are those bodies who look at regulation going to be happy that you are doing this in the form of a pilot? So then you can create the evidence base to then go down your regulatory journey. I think there's ways in which you can do it because of that all costs money to obviously go down the regulatory pathway. But if you can form it in a way that you are putting it under the guise of a pilot, there's very clear outcomes. Equally, let's say it's an AI product, they're making sure that the clinician is still making the decision, but you're evaluating the product. I think that there are ways in which you can get some things out into a kind of pilot without spending tons of money, but it does need to get to proof of concept. And equally, there are people who can guide you to make sure you're not falling foul of the kind of regulations in the MHRA as well.
Brilliant. Thank you so much. And thank you to everyone who's joined today and for the questions. Thank you to my panelists, Dr. Krishan Ramdoo and Professor John Terry. It's been a really interesting conversation. So thank you. And there'll be information and opportunities to gather for more information on this topic from our own ambitious social channels. Thank you all.
Thank you.
Bye.
Thank you.